Good morning. Myself, Dr. Nutta Nadia. I am currently working as an assistant professor in the Department of Cardiothoracic and Vascular Surgery in UNMICRC Hospital and Research Center. Today we are discussing the topic of atrioventricular canal defect. Today's learning objectives will be the historical aspect, the definition and the overview of the AVCD, the embryological basis, pathophysiology, classification and spectrum of the disease, what are the natural history of the disease, what are the clinical features, investigation, and what are the management in atrioventricular canal defect. Coming to the historical timeline, in 1948, Rogers and Edwards first described the morphology of the atrioventricular canal defect. Afterwards, in 1956, Vaca and Edwards first coined the term partial and complete AVCD. And in 1966, Rastelli first described the morphology of anterior bridging leaflet and gave the classification that is known as the Rastelli's classification. In 1980, Bharti and Lev coined the term intermediate and transitional AVCD and also give the anatomy of the conduction system in atrioventricular canal defect. In 1954, Lilheli first done the successful surgical repair using a cross circulation in patients with atrioventricular canal defect. Afterwards, Kirkland, Watkins and Gross has done the open repair using the oxygenator. In coming to the definition and epidemiology of the atrioventricular canal defect, which is also known as the endocardial cushion defect and atrioventricular septal defect. The main lesion here is the deficiency of atrioventricular septum. It is not just a hole that is like ASD or VSD, but it is the combination of the ostium primum ASD plus inlet VSD plus common atrioventricular valve. Here we see as a left to right shunt, and there is a progressive pulmonary hypertension that is seen in the patients with atrioventricular canal defect. 1 in 2000 live births, there is an incidence of atrioventricular canal defect has been seen, which is the third most common congenital heart disease, and 3 to 5% of all congenital heart disease have atrioventricular canal defect. It is slightly more common in the female patients, though evidence are not that much. Coming to the embryology, it is basically if we can say it in the one sentence, then it is the failed fusion of endocardial cushions between 4 to 8 weeks during the gestation. In week 4, the cushions begin forming at the AV canal from the cardiac jelly. In week 5 to 6, the superior and inferior cushions grow and fuse. If week 7, the septum primum fuses with the cushions and closes the ostium primum ASD, and in week 7 to 8, the inlet ventricular septum grows and fuses with the endocardial cushion. If there is an incomplete fusion, there is a spectrum of atrioventricular canal defect that can develop from the basis of extent of the disease. Other molecular bases are the mutations like in GATA4, YBX5, NKX2, 5. It is also common in patient with trisomy 21, maternal rubella, and maternal diabetes mellitus. If there is a normal development, the cushion fuse, which leads to the complete AV septum and separate mitral valve and tricuspid valve. But if the fusion is incomplete, there is a gap that forms the primum ASD and inlet VSD, and which give rise to the common AV valve orifice. Coming to the pathophysiology, in pathophysiology, because of the ASD and VSD and common AV valve, there is a left to right shunting, which lead to the increased pulmonary blood flow. There is more QP than QS, which ultimately leads to the pulmonary hypertension, that is the increased pulmonary artery pressure, then further lead to the heart failure in some patients, and in some patients there is a reversal of the shunt, that is right to left shunt. So these patients need early surgery. If you intervene before the stage of pulmonary hypertension, then there will be increased survival. The main step that we can operate is the ideal surgical window before the patient develops severe pulmonary hypertension before meningerization. Incomplete AVCD causes greater hemodynamic disturbances than the partial AVCD, which leads to the pulmonary vascular disease. Coming to the spectrum of the disease, there is a different lines wise spectrum of the disease according to at which point the development has happened. In first, the partial AVCD. In partial AVCD, there is a primum ASD, but there is no VSD, but there is a cleft in mitral valve which leads to mitral regurgitation. Here there are two separate AV valve orifices that we can see. In transitional AVCD, the primum ASD plus small VSD is there, two AV valve orifice is there, and the caudal attachment to the VSD crest. In complete AVCD, there is a large ostium primum ASD, in large inlet VSD, and a single common AV valve orifice which leads to left to right shunt. There is increased severity. Here in image you can also see the in AVCD there is a atrial shunt, the ventricular shunt, and atrioventricular shunt. Here the two AV valve orifice and the one AV valve orifice. The primum partial AVCD, the partial AVCD, intermediate AVCD, and complete AVCD. Here in the image we can also see the same thing, but in intermediate, transitional, and partial AVCD there is a similar AV valve anatomy. The tongue of the tissue decides the common AV valve into right and left component by connecting the anterior and posterior bridging leaflet centrally. Coming to the Rastelli classification, which is based on anterior bridging leaflet. There is a three types he has described: the type 1, type B, and type C. Type 1 is the most common type seen in the non-Downs patient, that is 70%. Here the superior and inferior bridging leaflet caudal attachment is to the ventricular septum, crest of the ventricular septum. Here in the image also you can see that. In type B, it is a very rare, less than 5%. Here the caudal attachment is to the papillary muscle of the right ventricle. Here also you can see the same thing that is described in the image. In type C, which is the most common type in the Down syndrome, there is a no caudal attachment, so you can see that it is a free floating leaflet which is seen in the Rastelli type C. Coming to the natural history of the complete AVCD. In a natural history of the complete AVCD, 3 months 20 to 30% mortality is seen. With age of 6 months, 25 to 30% are death by already age of 6 months, and at the age of 1 year, more than 50% patients have seen the mortality. There is a slow development of the Assenmeyerization by 2 to 3 years, and in adults it is not seen mostly. What are the consequences in these patients? The consequences are the heart failure in infancy, which develops due to left to right shunt, and it causes the biventricular volume overload, and it leads to the heart failure in this patient. There is increased pulmonary blood flow, which leads to pulmonary arterial hypertension in these patients. In patients with the Down syndrome, the progression is very faster as compared to the chromosomally normal patients. With developing pulmonary hypertension, gradually there is a shifting of left to right shunt to the right to left shunt, which leads to the Eisenmenger syndrome. AV valve regurgitation will further increase the load of heart failure in this patient. Without the surgery, the prognosis is very bad. More than 50% mortality is seen by the age of the 1 year. Whereas in the natural history of the partial AVCD, the key difference here seen is the only atrial shunt is seen. There is no VSD, so it shows the much slower hemodynamic disturbances in this patient. Slower clinical course is seen. Mitral regurgitation is progressive in these patients. Adult, we can also see the adult presentation in the partial AVCD with unrepaired partial AVCD repair. Pulmonary hypertension is delayed in this patient because of this only ASD level shunt. Atrial fibrillation is more common in this patient because there is a adult presentation with the arrhythmias. The prognosis without surgery is far better than the complete AVCD. However, the expectancy is reduced in general population. Coming to the clinical features of partial and complete AVCD. Partial AVCD patients are mostly present in the childhood or the adulthood, where they present with the exercise intolerance, the arrhythmias, the palpitation, heart failure in very later age. Patient in signs of this, a fixed wide split S2 is seen, pulmonary ejection systolic murmur, and apical pansystolic murmur is seen. In complete ABCD, patient presents in infancy with heart failure mostly, tachypnea, poor feeding, failure to thrive, recurrent infections are seen, cyanosis if SMNGs are already developed. In signs of this patient are hyperactive precordium, loud P2, hepatomegaly, crepitations are seen in this patient. Coming to the what are the factors that combines the Down syndrome and the AV canal. 40 to 50% of complete ABCD patients have Down syndrome, and more than 50% of Down syndrome patients have congenital heart disease, most commonly AV canal disease. 3 months is the optimal time for surgical time for Down's patients because they developed early pulmonary hypertension. Why these patients need early surgery? Because these patients has pulmonary vasculature that is already abnormal. There is a obstructive sleep apnea which leads to chronic hypoxia and faster pulmonary vascular disease development in Down's patient. There is alveolar hypoplasia and SN mingerization develop faster in Down's patient. What is the management consideration that we can thought of in patients with Downs with AV canal defect? That surgery by 3 to 6 months is the optimal time to prevent the irreversible pulmonary hypertension, screen for obstructive sleep apnea before the operation, manage hypothyroidism adequately. This should be the multidisciplinary team approach with involvement of the cardiologists, genetics and developmental pediatrics. These patients need the long-term follow-up in development of mitral regurgitation also. So with modern techniques, though 10 years survival of Down's patients undergoing ABCD repair is comparable to the chromosomally normal children in this era. There are 3 major investigations apart from the common routine investigation that we can use in patients of AV canal defect to diagnose this and to study what are the surgical approaches can be used in these patients. First one is the electrocardiography. There are 3 criteria that we given by Toscano Barbosa in 1956 that are the prolonged PR interval seen in the 50% of these patients, left axis deviation and the right ventricular hypertrophy due to right ventricular volume overload. In echocardiography, these are the findings that we can see in these patients where the left axis deviation is the pathognomic of AV canal defect. Coming to the chest X-ray findings, cardiomegaly is seen which is severe in complete ABCD, pulmonary markings are increased which is markedly increased in complete ABCD, pulmonary hypertension signs are common and age of the abnormality is mostly finding in infancy in complete ABCD and in later age in partial ABCD. There is pulmonary plethora that is seen in the chest X-ray with prominent pulmonary artery marking. Coming to the echocardiography is the gold standard of investigation that we can use for AV canal defect. There are mainly 4 things that we can see and we have to see in echocardiography before operating for AV canal defect. The first one is the AV valve assessment. What is the size of atrial and ventricular components of the leaflets? What is the morphology of the bridging leaflet, whether the what is the left AV valve regurgitation, whether it is severe, mild or moderate, what is the leaflet cleft size and what is the direction of the cleft. Coming to the ventricular anatomy, what is the balance, that is the left ventricular and right ventricular ratio. We have to see this ratio to measure to go for whether the biventricular repair or the univentricular repair. What are the septal defect size and what is the location of the defect, what is the anatomy in unbalanced AV canal defect that we have to see, and fourth is we have to see the additional lesions like PDA, tetralogy of Fallot, DORV and heterotaxy. Here you can see the subcostal and apical 4-chamber view of the echocardiography in AV canal defect. Subxiphoid view, that long axis view, we can see ostium primum ASD, additional ASDs and gooseneck deformity in these patients of complete AVCD. In the image you can see here this angle is reduced of outlet and inlet, so it is seen as the gooseneck deformity in echocardiography. Coming to the unbalanced AVCD, 10% of the AV canal defect patients are present with the unbalance in this patient. The unbalance can be anatomical unbalance, that is lack of symmetry in the size of the valve, and physiological imbalance, that is the lack of symmetry in the distribution of blood flow between the pulmonary and the systemic circulation. Here you can see the this is the balanced ABCD where the right component and the left component are almost equal. In right dominant unbalanced ABCD, the right component is much more than the left ventricular component, and in the unbalanced ABCD, left dominant, the left component is much more than the right component. Some proposed echocardiographic parameters are below described, where to define the unbalanced ABCD, whether it is the left ventricular dominant or the right ventricular dominant. One of these criteria is AV valve index, where the left atrioventricular valve component area divided by the total atrioventricular area. If it is between 0.4 to 0.6, then it is the balanced atrioventricular canal defect. If less than 0.4, then right ventricular dominance, and if more than 0.6, then left ventricular dominance. Less than 0.19 extreme imbalance, it will lead to single ventricular palliation. Another one of these criteria is right ventricular left ventricular inflow angle. If the angle is more than equal to 114, then it is the balanced ABCD. If it is less than or equal to 114, then it is unbalanced ABCD, and it will lead to single ventricular palliation. Coming to the cardiac catheterization, it is indicated for the assessment of operability in patients with pulmonary hypertension. If pulmonary vascular resistance is less than 8 Woods unit, patient is operable. In these patients also, you can see the gooseneck deformity of LVOT and LV angiography in this study.